can see my screen now?
Yes.
Okay, perfect. Okay, so I will speak about a case report that I did for treatment of aseptic necrosis of the femoral head, and was treated with biological screw. That is the problem. So the case report, I will talk about this question. Osteonecrosis of the femoral head, multifactor origin. Then, just a second, okay? Just a second, sorry, one moment. Sorry, one second, I'm sorry, but I must close the file of the patient, other way they cannot do the billing and then they pay me. 1 second, sorry, 1 second only. 1 second, I'm sorry, I'm very, very sorry, but it was delayed and I...
That's okay, we've all been there.
I'm very sorry. Allora, 1 second, just let me close this. I will just write the X-ray. 1 second. Hip.
Okay, take your time, Dr. Piracci. We'll stay with you.
I'm sorry. Allora, pelvis. Okay, so I did these things. We come back to our methods. Okay, just I will go. Okay. So we speak about. I give just a small introduction about the osteonecrosis of the femoral head. So we have a multifactorial origin. Affect a person of 40 to 60 years, and 50% of the cases are bilateral, and in 10% may also involve other joints. Pain, alteration of anatomy and the biomechanics of the hip, and the growing disability constitute the natural history of this disease. So we can see here on this picture that is like a circle, means there is an occlusion of a small arteria, then there is edema extravascular, compression of the vein, and there is stase. This causes a lack of blood in the head of the hip, and then we have a avascular necrosis. So just a small history about this who discovered was a Scottish doctor, Alexander Murrow, who was the first that identified it in the first half of the 19th century. Then Professor Gruyère was the first to attribute the disorder to an aberration of blood circulation in the head of the femur. So since then, the diagnosis of this disorder has gradually grown thanks to a technological evolution of the great awareness. So osteonecrosis can be of traumatic or atraumatic origin. The traumatic form has an originating causal event and is isolated to the particular bone fragment involved. The atraumatic, that is the most common form, has multiple etiologies and may involve multiple bones. So the traumatic form of osteonecrosis occurs in 10% of composite femoral neck fracture, 30% of displaced femoral neck fracture, and 10% of hip dislocation. When I speak about femoral neck fracture, I mean that there is the fracture of the neck on the base of the neck, because if the fracture is subtrochanteric or intertrochanteric, this kind of complications is very, very rare. The intake of corticosteroids also contribute to the traumatic form of osteonecrosis in 25% of the patients. The male to female ratio is approximately 4:1. At least 50% of patients with atraumatic osteonecrosis of the hip are predisposed to bilateral osteonecrosis. Other bones may be involved in atraumatic form, including the shoulder, knee, and talus. So, it's a progressive degenerative disease in which we observe the necrosis of osteocytes, osteoblastos, and osteoclasts that populate an area variously defined femoral head. So diagnosis is often difficult in the first stage of the disease. For this reason, MRI is the best diagnostic method for osteonecrosis. The classification, we have 4 stages. Stage 1 and stage 2, the diagnosis can be done only with MRI. Stage 3, we can see some visible alteration in the X-ray. Stage 4, the X-ray is very evident, like also Cox arthritis. The therapeutic approach can provide for a bloodless treatment like pharmacological or biophysical, only in the earliest stage. More frequently, it is of the surgical type. In consideration of the early age in which the disease often manifests itself and consequently of the high functional demands, the importance of biological therapeutic options emerged that allow to spare the joint, avoid the collapse of the subchondral bone. The research perspective on which we have been focused for some years are aimed at the study of the pathophysiology of the disease and the use of the autologous growth factor and concentrated stromal cells that are provided to be fundamental in promoting the process of neoangiogenesis and reparative osteogenesis. So, the treatment second stage could be surgical with cord decompression plus arthroscopic technique of labral repair if we need, and regenerative medicine. So the goal is to reduce the pressure of the inside of the femoral head and of consequence reduce the pressure intra-bone to stabilize a normal vascular flux. Stage 3, we can try, but is not sure that we can get a good result. Stage 4, the treatment is the arthroplasty of the hip. So the history and examination of this patient, the case report, we had the patient with 65 years old, complains about 2 years right coxalgia that became worse and debilitating with progressive difficulty in the walking. So in the inspection, we found normal limbs conformated, but there was a reduction of with severe pain of the movement, inflection, extension, and abduction. So we did an X-ray, and with the X-ray, we saw that there was a problem in the hip, but the MRI showed a right osteonecrosis of the femoral head in stage 2, and the hip score is 25.7, so it's very, very high. So this is what we found it in MRI. Then just a very short brief on PRP. PRP is platelet-rich plasma, where the plasma, there are the cell fibrinogeno converted upon to activation of fibrin polymer scaffold of the new tissue synthesis. The platelet involved in the hemostasis and tissue healing secrete biologically determinate ratio of ground factor responsible for local signal. And we have many different kind of ground factor. So the primary objective in the treatment of the osteonecrosis of the femoral head is to implement early intervention to avoid or procrastinate implantation of total hip arthroplasty. The patient is treated in one surgical session with spinal anesthesia with the method that associates mechanical cord decompression of the osteonecrosis through the guide wire and biological action obtained through the introduction of PRP through a cannulated screw titanium equipped with holes. This is the PRP. We take just a little bit blood, we put in a vial and in a centrifuge, and then we can prepare the PRP. For the surgical approach, small incision was done with centimeter distal to the great trochantere. Then we put inside just a key wire that guide us. Then we drill and we insert, we drill with the 9 millimeters diameter for drill. And we put inside this screw, but how you can see there are some holes. And in the screw, we put the PRP. So the result is a significant and immediate pain relief, disappearance of the claudication, postural recovery, immediate results of the normal daily activity, and suspension of all analgesics. Thank you very much for your attention.
Thank you, Dr. Massimo. Does anyone have any questions?
Dr. Massimo, thanks
Yes,
for your speech. It's very interesting, very impressive. The PRP had been widely used in some hospitals in China already, but the investigation and the investigation about the effectiveness is still going on. I want to hear about your experiences for using PRP. How many cases and how about the 2 years or 3 years follow-up?
For this specific case, we treat in our center in the last 3 years about 8 patients, and of these 8 patients, I can say that 50% of them we had a very good result, because maybe it was an early stage of osteonecrosis. But for 4 of them, after some months, we went for arthroplasty of the knee. Now, I'm trying to study a different way of approach about this question, and we are just trying to put inside the stem cell, so the mesenchymal cell, and then we'll see what's happened. I want to now do a study to put the mesenchymal cell in the head of the hip and also in the joint. So we try to make something also inside of the joint, because if there is a early stage of osteoarthritis, you know that the subchondral bone is the major problem for osteoarthritis, no? So maybe we can see if in arthroscopy also we can do some something putting the stem cell in the subchondral bone and see what's happened with the developing of osteonecrosis. But this is a work in progress. You know, it's not easy. Yeah.
Oh, it's impressive. Looking forward to your new big discovery.
Yeah.
Thank you.
Thank you.
Can I ask something?
Yes, please.
do you think there would be any point? I mean, assuming I work in an area that I'm not sure that orthopedic surgeons will go through for that screw decompression technique. If I was just to use regenerative injection therapy of some sort into the hip by itself, do you think that could bring any results?
What you mean in the joint hip?
In the joint, yeah.
In the joint, I use regularly PRP and also stem cell. What I saw.
I'm talking about in the case of the osteonecrosis, though. I mean, I use it for hip osteoarthritis, and I get very good results.
Just I want to answer about this question for osteoarthritis. Yes, we use regularly PRP, and now I'm using more than PRP. I use also stem cell combined together, and sometimes I put also ozonotherapy. So I will do a mix of ozonotherapy, PRP, and stem cell. This is why, because ozonotherapy is an antioxidant, and it's very important also to produce a neoangiogenesis in the capsula of the hip or the knee or which joint you use, plus the stem cell and the PRP. PRP I use like a booster, means that we try to guide the stem cell through a particular kind of cell that we need in this case. I can say that the pain is reduced. I have one case also very interesting with a complete rupture of the adductor muscle. Okay, I use PRP only without stem cell because the patient don't have the money to do the stem cell. We use PRP, and I have the MRI before where is shown complete rupture with the distance of 3-4 centimeters of the muscle, and the MRI done after 6 months of treatment. Unbelievable, unbelievable. This is a football player. He came back to play football with a little bit pain than before, and there is a scar of the muscle with this treatment. I did with ultrasound guide. Amazing, amazing.
So can I ask another question about that? If you do such a treatment on let's say PRP on the adductor muscle or some sort of tear, what's your post-treatment regimen? Do you immobilize the patient for a certain amount of time, or what do you do? What are your instructions?
No. In this, it depends. But in this case, I didn't mobilize the patient because we started the treatment after some months. Because when I saw the patient not inactive. I saw the patient after 3-4 months that he broken the muscle. So it was not acute. In this case, I didn't immobilize the patient. I just told him to keep quiet, means don't run, don't do exercise. And then he came back for ultrasound. We saw that was that good result. After 3 weeks, I give another shot of PRP. And also after 2 weeks, again, another shot. 3 shots of PRP. Then he started exercise of elongation of the muscle. And then he started to run to improve the muscle. I saw after 6 months, and we did an MRI. I was very surprised. I will do a publication about this case because it's very interesting. So no mobilization in chronic, we can call chronic, but in acute. If I do in acute, for example, I did one patient 3 weeks back. He got a sprain, rupture, partial rupture of the quadriceps muscle. I put him in a brace. I did PRP. He got the brace for 2 weeks, and then I removed the brace. He started to do exercise, and the result is very, very good. Also, I'm very happy.
Thank you. Thank you very much.
Thank you for your question.
Dr. Massimo, I have a question. For the early stages of osteoarthritis, how would you compare doing PRP to just using a brace, like an unloading brace?
But I think that is not could be means there are different kind of thinking. Yes, the brace can be useful, as can be useful also osteotomy. tibial osteotomy in an early stage of osteoarthritis with the patient with varus or valgus knee, but could be combined therapy. I don't like too much to do osteotomy. I tell you why, because I saw in my life now 30 years that I'm doing this kind of job, that only osteotomy is not enough, because you know, osteoarthritis is also could be a genetic part of the pathology. So also, if you correct only the axis of the leg, maybe it could be not enough. And then when you do the arthroplastic of the knee, could be a little bit more complicated, because you change the axis of the tibia, and then when you do the cutting of the tibial plate and you try to fix the plate, maybe you can find some difficulty in the implant. So maybe the brace could be a good idea. Brace plus PRP could be a good idea.
Okay. All right. Thank you. Does anyone have any more questions regarding this talk? Okay. Dr. Massimo, would you like to do your second talk now as well?
I prefer wait some, maybe you can ask somebody, because I have 1-2 patients to to see back from the X-ray. Okay. So I can see this patient and then I will do my second speech, if for you is okay.
Okay, okay.